Transitional Age. I hope everyone who is participating could benefit from the panel of speakers and the speeches which are all on this concept. There are three of us. I would open the panel with introducing some of the concepts important in terms of psychiatric disorders for this age group, and then Dr. Motlagh is discussing mental health and mental health services for this age group, and then we go on to the next speaker, who is the last one for this panel, Dr. Motlagh, and she is going to share with us her experiences and knowledge about what's going on in the U.S. in terms of services provided for this age group. So I just want to share with you some of the concepts important to know before discussing any psychiatric issues in this age group. We all know that most psychiatric disorders, including psychosis, suicide, depression, and many other psychiatric disorders, often begin, and the age of onset is usually around adolescence. So this is a very critical period in terms of understanding the concept, the process, and how things get started in terms of psychiatric disorder. It's also important to understand uh, developmental issues and what goes wrong in terms of development for this age group. Um, the first thing we need to know and the first thing to acknowledge and have a deep understanding about is the concept and what we mean by transitional age group. Um, there are several words, several concepts which are used interchangeably. And in terms of history, they are not that old. Actually, they are uh, uh, very recent uh, phenomena, recent description of those concepts in the literature. And I briefly describe some of these words in order to have a better understanding of what we are talking about, and then um, we have a chance to discuss other issues. Um, let's see. Okay. WHO uh, have, have described these words as we see in the consecutive in the next couple of slides. Young people, what we mean by young people by WHO definition is everyone who is between age 10 and 24. Youth, which is the focus of our discussion today, is everyone who is between 15 and 24. Sometimes it's 14 through 26, 14 through 24, but more often, what we mean by youth is anyone who is between 15 and 24. And also sometimes we use adolescents. Adolescence is everyone who is between 10 and 19. Um, and this concept, either youth or adolescence, which are now defined and described differently, but overall, the concept of this transitional age is something new, as I said, as I mentioned earlier in the discussion. Um, if we want to have a better understanding of what we mean by being new, if we go back to history, in terms of literature, Plato was the first one. We have some writing or understanding or documents in terms of uh, what he meant for what he meant in terms of education, children, and how he describes education, training, and so forth. And in his classic works, especially um, his iconic book Republic, he described the main task of education, formal education in children, um, very carefully and in very detailed. He believes that teacher is someone who carries a torch and guide his pupils into darkness of cave. And the goal of education is not individual growth. It's to learn how a good citizen is like and how to make rational decisions in the Platonic ideal city. As we know, he believed in ideal city. So learning is linear, and everyone goes through the same linear uh, learning, and not there are not different stages as childhood, adolescence, and adulthood. So everyone we learn is incremental in terms of getting older and moving on to the next stage. And there are actually no stages. It's just increasing your knowledge, increasing what you know, and the goal is to become a good citizen in his ideal city in which everyone is supposed to behave in an ideal way. And basically, the more we learn, the more knowledgeable we become. And through education, an ignorant person becomes a knowledgeable person without going through different stages. Um, an adolescent is someone who knows more than someone who is in his childhood years. And an adult person is someone who knows better, and he knows a lot much more than someone who is in his um, adolescence. And as we know, he goes on and describe other stuff as well. For instance, he believes in governance being belonging to philosophers, and philosophers are only unique people deserve to be governors in government. And in his view, children are naturally miniatures of more knowledgeable older people. They are not qualitatively different. They are just quantitatively smaller, and as they know much less than older adults. And development is basically a process of increased wisdom and knowledge in a very incremental linear way. Um, um, the, the modern understanding of, if we could call it modern, the modern understanding of development was like what Plato said until Jean-Jacques Rousseau introduced a new conceptualization of childhood. And he was the first one in modern documented history who separated childhood, and adolescence, and adulthood. And again, he has a very iconic, famous book by the name of Emily. Emily is a girl who is supposed to be an ideal citizen, and in the book, he describes his philosophy of education. It's quite interesting. Jean-Jacques Rousseau, as we know, he was one of the key figures in French Revolution, and his book on Emily was published at the same time as he introduced the concept of social contract, which is basically one of the key elements of democracy. His book was quite controversial, and um, when he published his book, not everyone was happy, especially church and um very orthodox Catholic Christians. And actually, for several years, his book was prohibited from uh, circulating or getting published, and it was burned. Actually, everyone who has the book, if he get caught, his book was burned. And the name Emily is a pseudonym for a citizen raised in an ideal way. He has also um, another introduced another name by the name of Sophie, uh, who is a citizen who will be the Emily's husband. Um, he has four chapters in his book. The first three ones are on Emily's training, and the fourth chapter is on adolescent as a separate um, um, age period. So Jean-Jacques Rousseau was basically the person in Western modern philosophy who separated adolescence from childhood and also from adulthood. Um, and for the he describes in his book many emergent new phenomena as Emily gets older and goes through adolescence. For instance, both Emily and Sophie. For instance, um, um, Sophie is described as someone who is capable of understanding complex human being emotions, particularly sympathy, when he goes through adolescence. And he wasn't able to do so beforehand when he was in childhood. And Rousseau argued that the child was not able to put himself in the place of others. And when he gets to adolescence, um, he gains that capabilities. Um, and he gets ready to be socialized. So as we see, he separates childhood and adolescence. Um, and this is something very new in our understanding of development and growth. Um, the other historical events we need to understand before understand what happened before conceptualizing transitional age group was industrial revolution. Um, Beforehand, the human being lived in what we call as agricultural uh, era. When industrial revolution happened, um, work and home had to be separated. Beforehand, the whole family was living on a farm, and everyone was together all the time. And there was no separation of work and home. Once we get to the era of industrial revolution, um, uh, a child needs to be trained. Uh, a child needs to get training for doing um, kind of in the kind of stuff which is needed outside of his farm or his family's farm. So he has to leave the house every morning and works in a factory um, or somewhere in the city, not um, in a village he lives. So inevitably, work and home were separated, and job differentiated happened. Beforehand, everyone was involved with taking care of uh, house house uh, works. Everyone was involved with farms. Everyone was involved with everything that happening in everyday life. Once you have work outside of the family and farm, you need to differentiate job description, and everyone has to be specialized. Everyone has to learn things. Everyone has to go through classes and learning. And inevitably, migration to cities happened. Um, Again, uh, in this era, adolescence becomes important as societies become more industrialized. A child needs to be separated from um, uh, his or her own family and get training, get exposed to kind of education taught in cities, um, and and that has to happen before becoming adult. So adolescence becomes an age uh, uh, years with very important tasks. Adolescence is a period of time you need to become ready in order to take important jobs and become an independent person. The third phenomenon was obligatory education. Obligatory education was also part of industrial revolution and post-industrial revolution. Why do we need obligatory education? Because everyone needs to be prepared to take on tasks outside of farm, outside of traditional way of living. So as a result of this, they gradually develop their own culture because they need to be together to participate in teaching and to learning, um, and the mere fact that they spend time together in cities, in large cities, as a separate group with separate, unique teachings, that makes them unique and differentiated from other age groups. And now, at this time, when we discuss and think about transitional age group or adolescents, um, we have new phenomena as well. There are many issues unique to this generation, and I just called some of them some of more important ones. Um, a very unique phenomenon no one has ever experienced in history, especially during um, adolescence, is that everyone um, um, is connected to everyone else simultaneously. Simultaneous connection with others, with the rest of the world, is a very unique and novel phenomenon. Uh, and that has um, very unknown consequences. We don't know for sure what would be the consequence of being connected simultaneously with others in the world. Um, when we grew up, when our fathers grew up, everything was static in terms of time. It doesn't. It didn't make sense to get connected uh, simultaneously with others in the world. So this is a very unique phenomenon and has many layers of influences on other issues. The second unique uh, first, as I call it, first, is for the first time you are born um, somewhere, but you could live somewhere else, and you could work somewhere else. It's nothing uh, like that in the history. So where you born, uh, where you live, and where you work could be all different, as we have many examples because of the kind of economic situations we are now experiencing. So um, this is very important, and this has again um, many unknown consequences. We are not someone typical for the place we were born. Um, we have many exposures to many places because these are not as, necessarily the same. Being born, you could be someone who is born in some city, live another city or outside of the country, and work in a different country. So in a way, you are multinational, or you are kind of um, international, and for at least you are exposed to many things at different developmental stages. And again, nowadays, everyone, including adolescents and youth, um, everyone is exposed to, or potentially could be exposed to various ways of violence, which is unique to this era and this century. Cyber terrorism or um, cyber attacks, cyber bullying, terrorism, etc. These are new phenomena, and we don't know for sure what would be their impact on normal development as well as developmental psychopathology and the kind of pathology we are facing uh, at this age group. Um, and another phenomenon, which is also something new, is that in terms of statistics and numbers, majority of youth live with only one parent. For the first time in history, families with single parents are more in terms of numbers compared to um, parents living together. And again, that has many unknown consequences. Um, and another phenomenon, another um, observation is that for the first time in history, source and control of information is not parents. Um, and actually, in so many ways, parents know much less than their siblings in terms of everything. Um, and this has many ambiguous, unwanted, and also unknown consequences. And nobody knows what that means. Um, uh, we used to hear about advice of our parents that we have um, we have more experiences. We know how to do things because um, um, we have broken so many shirts, as we want to translate it into English. But that's not the case anymore. Communication, social media, and so forth uh, has made it impossible for parents to be on top of everything. And actually, this is their siblings who are on top of things. Um, Natural disasters and wars could lead to massive migration and ruthless civilization. A very recent example would be a war in Syria, which made 10 to 12 millions of Syrian refugees uh, get displaced to so many other countries. Um, this massive migration um, make make them um, vulnerable and also make them unpredictable in terms of the way they're raised. Um, um, this is actually something new in terms of the level and um, impact of recent wars. Um, and also another observation, we could have many observations actually like this, but one of the apparently important observation is that gender-related behaviors are now considered something biological and not necessarily impacted by social factors, at least not all the time. And contribution of biological factors for gender-related behaviors are nowadays acknowledged. And this has many implications as we are beginning to understand. So what I said means, in a word, that we are living in a very complex world, and we need to take a very modern ecological framework in terms of looking at psychiatric issues for this age group. Ecological framework, in a way, means that we need to reconsider all the phenomena which we used to take a look in a very traditional way. And ecology of uh, environment for this age group is very important. And our understanding is getting more and more complex and also um, more interesting. So I'll stop there for now. And I think we could now move on to the next speaker, who is Dr. Mahtab Motamed. Dr. Mahtab Motamed is with the Department of Psychiatry at Tehran University of Medical Sciences. And actually, she is in charge of transitional age group uh, um, interest groups in the hospital. and she's going to talk about mental health services in Iran. Thank you.
Thank you so much, Dr. Alaqand. Yeah, this is Mahtab Motamed. Today I will talk about youth mental health, but before that, I just want to take time to share my screen. You can find me at my Gmail if you want. In my presentation, I'm going to give you a picture of mental health profile of transitional age youth and also a profile of service youth in this age group. But before that, I just want to put some emphasis on what Dr. Alagban said about this new life stage. As Dr. Alagban said, due to different situations that we have in our society and in recent years, a new life stage has been emerged with its with its specific and particular characteristics and features. People in transition struggle with their identity exploration. They are somehow at the beginning of their road to the life. They do not have any fixed jobs. They do not have any fixed high education. They have not chosen yet. And also they are not in serious relationship and they are experiencing and practicing all these things. So instability is something inevitable for them. Also, they focus on themselves to reach to their goals and to somehow fix all these instabilities. They are not child or adolescent anymore, but they are not regarded as adults yet, and because of this, they may feel in between. But of course, they have this long road of life in front of them, and they may see a lot of possibilities in front of them which gives them an optimism. Um, Along with all these features, the society does not regard them in a consistent way. In a legal situation, they are regarded as adults and they have own legal responsibilities. But also, like adolescents, they do not have any private or any specific or specialized care provider, and this may put them in a paradoxical situation. With this short emphasis, I just want to talk about youth mental health. Of course, data or studies on this particular age group is not that much, but according to a study, 12 months prevalence of any psychiatric disorder is 40% in this age group, which is more than any other age group in people in normal population. And the most common problems in this age group are anxiety disorders, mood disorders, and also substance use disorders. Based on another study which has been held in New Zealand, the 12 months prevalence of any psychiatric disorder was 22 in 15-year-olds, doubled up to 40% in 21-year-olds, and 48% in 26-year-olds. And the increase in substance use disorder in this age group is really huge. You can see in this slide that in age group between 12 to 17, the prevalence of substance use is about 9%. But when we go to the age group between 18 to 25, This increases to 21%, which is somehow more than 3 plus. And also it declined after 26-year-old. In conclusion, we can say that young adulthood is a high-risk age period with the most the worst, maybe the worst outcome of mental health. Young adults compared to adolescents are 49% more likely to abuse alcohol, and they are 17% less likely to receive annual preventive care. So they are somehow different from adolescents. And it is very important, especially for, I think, mental health professionals and psychiatrists, to regard that many many psychiatric disorders start from this age group. Onset of many psychiatric disorders are in youth age, and also there are some disorders that started from childhood that do not disappear when people age out to adulthood. This is somehow a common problem in our practice, that we see some patients that previously were diagnosed with some disorders like ADHD or autism in their childhood or adolescence, but when they age out to adulthood, the adult services do not consider these disorders, especially neurodevelopmental disorders. So we as mental health professionals should know that many disorders from childhood and adolescence continue to live after aging out to adulthood and transitional age use period. And also, this age group is at high risk for co-occurring disorders and comorbidities that we should consider. But what about the service use? What is the profile of service use? Till now, we have understood that the prevalence of mental health disorders are high in this age group. But what about the service use? This study has explored the patterns of mental health service utilization for transition age youth and young adults in United States. As it is shown in this slide, the study has categorized the population to three groups: pre-transition group, transition group, and post-transition group. As we can see in here, the number of inpatient care utilization has increased in transition group, but the outpatient care is decreased. How can we translate, or how can we interpret this data? Maybe this can be concluded that the prevalence of outpatient service use is not that much in a transition group, which leads to more severe conditions that need inpatient services. So this highlights the importance of early intervention and prevention, and also access to outpatient services. A series of researches has been done in UK to explore transition from child to adult mental health services, which is abbreviated to TRACK study. Again, as it is shown in this picture, we can see here that from the cases that reach to transition boundary, only 22% never referred to adult mental health services. And among those who were referred to adult mental health services, uh, 500 were refused by adult mental health services, and alternative suitable services were present only for one case, which is lower than 1%. But when we are talking about suitable services, what are we exactly talking about? What are the essential features of mental health services for this specific age group? Um, the services for young people should be coordinated and continuous. It should also be flexible and should be aligned with developmental needs of this age group, and also should be adjusted to the specific needs of this age group. It should be youth-centered and community-centered, and it should consider the educational needs and employment of this group. We can categorize the essential features of mental health services for transitional age youth to three different categories: systemic features, organizational features, and programmatic features. In systemic aspect or in systemic view, we should try to promote coordination, continuity, and communication, and try to avoid any kind of fragmentation. In organizational aspect, the system and the service should be flexible and inclusive and should be appropriate for developmental needs of youth, and also it should be at the same time open and consider the autonomy of youth. And services which are rigid and exclusive are not acceptable, are not welcomed by youth. And in programmatic views, we should try to, as much as possible, promote youth involvement, and we should avoid hospital centeredness. All of these features try to increase the compliance of youth, and try to increase and promote the outcome. But how can we implement these features to the services? Uh, Basically, two different models can be considered. One model acts like building, and one model acts like a bridge. In the first kind, um, the service tries to build a service for disorders with their first presentation in use. Um, it means that it starts its work with a new presentation. Um, so it may have some high initial cost, but it is a specialized and specific for use, and it is more use focused. Good examples of these models are Headspace in Australia and Headstrong, which I will talk about them in more details in my following slides. The other model targets existing disorders and tries to act like a bridge and tries to facilitate the transfer from child mental health services to adult mental health services. And this model may improve attendance and compliance of use, but these models may not address specific or specialized needs of use, and do not address first presentations in this age group. But building or bridging, which solution is the best fit? Of course, choosing between these two models is not that much easy, and it depends to many situations and many variables. But a wise answer, and at the same time conservative answer, will be that a mixture of building and bridging will work better. Now that I gave a picture of or a perspective of a mental health profile of use, and also mental health service utilization of use, I want to introduce some good examples of use mental health services for the last part of my presentation. This study, maybe my microphone is not working. Mhm. Sorry for the quality or maybe the noise of my microphone. Um, this study has been published in 2013. Maybe it is a little bit old now, but I think it is comprehensive. And it reviewed the existing examples of use-specified mental health services. Now I start with Headspace and Oregon Youth Health. If not the best, but one of the best known example of youth mental health services is running in Australia, and it is called Headspace. Headspace is working through primary care health, and it is somehow an enhanced primary care model for youth mental health care. It was established in 2006, and it targets young people, and by young people they mean people aged between 12 to 25-year-olds. It has a user-friendly atmosphere, and it is accessible through primary health care centers. And it has a one-stop shop structure, meaning that whatever youth may need for their health can be found in a single center. But it also has some links to schools, had some links to community-based organization, and also some links to more specialized services. Um, Four different kind of services are offered in Headspace: mental health services, drug and alcohol services, primary care services targeting general health, and also vocational and educational assistance. The programs are offered in different routes or different approaches, like school-based intervention and also internet-based programs. Um, let's take a look at the main presentation or main reasons for presentation to Headspace centers between youth. As it is shown, feelings are the most frequent reason for presentation to Headspace centers, with relationships coming afterwards. And as it is illustrated in this diagram, Most of the clients of Headspace are at mild or moderate stage of their disorders, which again highlights the importance of early intervention and prevention. And about 93% of young people who received the care were satisfied with the care they received. And up to 2013, 50,000 young people has access to these services through 30 centers all over the Australia. Oregon is a service which is more specialized and which is designed for more complex presentation, and it was established in 2002. It was evolved from the model, the EPIC model, Early Psychosis Prevention and Intervention Center, but it extended its works. And it is the Australia's largest youth-specific mental health organization. Oregon has 4 specialized clinics. A clinic for first episode psychosis, which is called EPIC, and it is a derivative of the first model that it has been evolved from. A clinic for youth people who are at high risk of psychosis, which is PACE clinic that works on personal assessment and crisis evaluation. A mood clinic that mainly works on depression and type 2 bipolar disorder, and also a clinic which is designed especially for youth who are emerging borderline personality disorder, which is called HYPE, uh, which is an abbreviation for helping young people early. um, Different kind of services and different kind of supports are offered in Oregon youth centers. Oregon offers a 2-year period of care which includes case management, individual supports and group supports, and also vocational intervention. Um, Beside all these things, Oregon has also inpatient units too. Uh, and annually, 700 young people utilize the service from Oregon. The other example, which is the last one that I will talk about, is Headstrong and Jigsaw model, which are located in Ireland. Um, the structure is somewhat like Headspace. Um, the Headstrong um, has an extension program, which is Jigsaw model, which is specialized for young people. And this is also a youth-friendly service. They have this phrase for themselves as a slogan, which is somewhere to turn to and someone to talk to. And like Headspace, the most common presenting issues for young people are their feelings like anger, stress, tension, and whatsoever. Um, um, Jigsaw also, again, like Headspace, offers many different supports like emotional, cognitive, and behavioral self-regulation supports, and also it addresses substance abuse, family issues, and learning disorder. By learning disorder, I don't mean learning disabilities. I mean challenges and issues in education. And it has been reported that problems like peer relationship problems or daily living skills problems are well addressed, but the outcome of the other kind of problems like housing and employment were not that much convincing. And about 5 to 10% of young people from Jigsaw may need to be referred to some specialized care. And in this picture, you can see the whole structure of Jigsaw. Jigsaw provide many different supports to young people, including brief interventions, including problem-solving models, including prevention strategies for self-harm. And also, Jigsaw tries to strengthen the capacity of the people surrounding the young people. And because of this, we can regard to Jigsaw model as a multi-layered approach and multi-layered system. And yeah, that was all. Thank you so much for listening to my presentation. Um, we can talk about any questions that you may have at the end of all the presentations. Thank you so much.
Thank you very much, Dr. Motlagh. Now we have Dr. Maria Motlagh, who is Chief of Behavioral Health Department with Connecticut Institute for Communities. Um, she has a very interesting background. She was with us at Tehran University of Medical Sciences. She was a resident of us in Ruzbe Hospital, and then she moved on to fellowship in child psychiatry. And at some point during her fellowship, she got a chance to go to Yale University for a research project we had there, and she stayed there. And now we are fortunate to have her. She has had many experiences with this age group, and I'm so happy to have her. Please, Maria, it's yours.
Thank you, and good afternoon, everyone. I'm so glad to be here as part of the presenters in this webinar. And
I can't hear you.
Oh, can you guys?
Okay.
I can hear. I can hear. Yeah, I can hear.
You have my voice now?
Okay, go on.
Okay. So I'm glad to be here. Thank you for inviting me, Dr. Alokband. So I would like to present my experience working with young adult population that I had a chance to spend 1 year of my fellowship here at Yale University. So I would like to share my screen first, and then we talk more about the concept of the transitional age youth. Okay, give me a second. Let me see. Sure. So you can see my screen, right?
Yes, go ahead.
Transitional age youth, the topic that is quite interesting and challenging. I learned from Dr. Alokband's presentation. Thank you for conceptualizing the whole concept and the new era of the modern age. And thank you, Dr. Motlagh. It was very insightful learning about other services in Europe and Australia. So I would like to have my agenda providing some basic information on definition of the transitional age youth called TAY, or why this age group are important for us as psychiatrists or child psychiatrists. And what do we know about this age group? and what are the important aspects of their development, including biopsychosocial development, and what are the importance of the mental health for this age group. And then I briefly talk about my experience at Yale during my fellowship as young adult psychiatry fellow. So the term of transitional age youth is a new term. I mean, at least in the United States, it has developed or defined 1995 by SAMHSA, which is the Substance Abuse Mental Health Services Administration, something equal to Mental Health Administration specifically for mental health in Iran. So this age group has been defined because it observed that these people, this age group of population, they get lost in terms of receiving services, particularly for population in this age group that they aging out from foster care services, that we're going to talk more about them. So what are the specific characteristics about a transitional age group? There are three, concepts about this age group that I would consider to be specific and important to consider. The first thing is, this is a unique developmental stage, as we know. So this is the stage of being very creative and having high abilities and strengths, and we want to change the world. And this is a transition when we change or transition from high school to college or universities. So we get somehow at some level dependent to get a job, or we have a different social role. Now we are not kids of our parents.
Maria, excuse me, could you make your slide full screen?
Yes. Give me a second. I thought this is full screen. Can you see it full screen now?
Yeah, thank you very much. Yeah. Great.
So,
great.
Sure. In terms of, developmental specification for this age group, as I was saying, this is the time that we have a different role to be a partner or being, not being just our parents' kids. So this is the age that we do most of the risk-taking behaviors. And this is the age that we identify ourselves as who I am and who I want to be in future. And this is also the developmental stage for us to get more complicated thinking by increasing our executive functioning abilities. So when this is the time that we set goals and we decide what we want to achieve in future. All these developmental aspects of transitional age youth, we're going to discuss more in details in a few minutes, are important and they are unique for this age group. And another aspect of this age group that I would consider to be very important, as Dr. Mohamed said, is this is the time that majority of mental illnesses are developing, or at least presenting themselves if they have not started in childhood. So major mental illnesses, including anxiety, bipolar, or psychotic disorder. We talk more about this later. And the third reason that makes this age group or transitional age group to be important and crucial in relation to receiving mental health services is that, at least in the United States, there is a challenge for a significant number of youth that they are aging out from foster care. So what is the foster care and what is the role of foster care in childhood? I'm going to talk about this in details in a few minutes, but as a short, introduction. So kids in United States, when they are under guardianship of their parents, so they might get removed from the guardianship of their parents for multiple reasons, including physical, sexual, emotional abuse, or being neglected. And then they get under custody of either Department of Children and Families or some other families. They foster these kids under their, parenthood, but it's going to be temporarily. And by age of 18, which used to be defined as age of adulthood, they age out from the foster care, and now they need to deal with their life as an adult. Okay. So what are the characteristics of psychosocial development in this age? Emotional development, as you know, and we all experience, there is a very intensified level of emotional expression in adolescents and young adults. So they feel first and then react or respond, which is different with what we experience as an adult. We usually think and react or respond. So unless we are in very extreme situation like being in love or being extremely angry, then our emotion takes ahead and run the decision for us. So, but for adolescents and young adults, their emotion comes first. And by the time that they get to that thinking level, so, they might, get in trouble. And pattern of the social engagement in this age group is specific because they want to push away parents and they want to move toward their peers. This is normal. So if you have an adolescent or working with adolescents or young adults, this is normal. This is not about not liking their parents. And there is a significant amount of the peer pressure that most of the time considered to be a negative, aspect of their development, but this is normal. They need to be included. They need to be part of the club, and they try to be accepted by their peers. And they also, as I said, as one of the most important aspects of their psychosocial development, they need to find new things and they need to get excited. And that's why they take the risk and try all unfamiliar things. And this part is kind of normal development to make them ready to leave home. Otherwise, they don't want to do anything. They want to stay with their parents forever. And they also, this is the age for people to be creative and they explore the world because they want to challenge all boundaries, all rules, and everything that shaped world around them. And they want to make a new world. And this is how they define their identity and being creative. So as you know, many artists or people who create things, this age is the time that people had their most creativity. So there are 3 milestones about psychosocial development in transitional age youth. The first one is mastery and competence. This is the time that people practice, or young adults, they practice to set goal and then delay their gratification for something else and achieve something. It could be a sport, it could be art, it could be their academic function, but they practice to be successful. If they don't have the chance of practicing being successful, so they wouldn't be able to hold a job when they get into the adulthood. And this is, the second milestone for this age is interpersonal relationship and social interactions. This is the time that, again, they practice how to interact with others. When they are a child, they can have a parallel, play with other kids or they interact, but during adolescence and young adulthood, they learn how to argue with others, how to negotiate, and how they build their relationship with others. This is a big milestone for this age. And as Dr. Alavan said, the self-definition and identity is, one of the main milestones for this age. So every kid or adolescents, they have some fundamental things from their parents, from their background, from their culture. And then when they get to the adolescence and young adulthood, they keep some of those fundamentals and they shape it to the way that they want to define themselves. So who I am in terms of their gender identity, sexual identity, cultural identity, and in general, who I am in relation to the world. So before moving to the biological aspect of the development in adolescence and young adulthood, I want to just make a point about, how rewarding drive is important in this age, which has a significant biological, reason for it. So we have a significant drop in dopamine system in young adulthood and adolescence, which lead them to have a very hyperactive reward system in their brain. And so they want to explore the world and they want to make the world excited and they want to, experience anything new. they get bored easily. So in order to be happy, they need to have a high surge or spike of dopamine to be happy, which is different from adulthood. For us, as someone who is in their adulthood or middle age, so it's not that hard to be happy. So if we get one day off from work, so we feel happy, and that happiness might stay a few days. But for this age, they need to have something extraordinary. And this lead them to have impulsive decisions because they need to that level of excitement. And this also lead them to be more vulnerable, to be addicted to drugs, for example, because the amount of, level of excitement that they get with certain drugs is higher than, what adults get from the same drug or substances. And there is a significant amount of hyper rationality that they push for things that they want, and they push away things that they don't want extremely. So for example, between doing their homework or video games, they rationalize it, why I don't want to do homework because this is boring, but the video game is, activating their reward system. And as I said, they constantly looking for something to excite them with any type of sensation. And those sensations are some things that needs to have a surge in terms of the amount of the excitement. And intensify emotions, we talked about this at the beginning. They get extremely emotional, and they read emotions in a negative way. They might read parents' emotion, like, why you are mad, why you are mean all the time. So they read emotions intensifying way, and also they express their emotions in an intense way. And in terms of their motivation, there are significant shift in terms of their motivation. If they like something, you can motivate them to do that thing to the end. But if they don't like it, it's hard to keep them motivated on those things that are on agenda as parents or grown-ups. So what happens biologically in terms of their biological development in adolescents and young adults is that there is as you know, in terms of the limbic system, which has a role in terms of reward system and also emotion expression. So limbic system is hyperactivated in this age, and also all reward circuit in adolescents. So they have, this limbic system include amygdala, hippocampus, hypothalamus, and parahippocampus. So they get irritable soon. They have significant mood swings. They can be happy 1 minute at the same conversation, they get angry and leave the conversation. So, and as I said, they read emotions differently. And in terms of their motivation, given the relationship between limbic system and reward circuit and brainstem, they might look like to be lazy. They don't care about things. Their sleep hours are different. There is a significant connection between brainstem, which is a regulator for their respiratory, heartbeat, awakening, and sleep, and their limbic system, which is extremely hyperactive. And now here we can see the frontal cortex, which is in charge of our highly executive function thinking, which has not been developed yet. So what is specific about transitional age youth is that they have the limbic system or risk-taking hardware, hyperactive and somewhat mature, but the frontal cortex, which is a regulatory hardware, is not matured yet. So as an adult, we have forward thinking. We can think about what I'm going to do tomorrow or next month. That's not the case for adolescents or young adults. They have a short span about thinking about the future. Or in terms of this mismatch and also lack of the connection between these two hardwares, if I see a police car behind me, so very soon I would pull over and think about what I need to do before police chasing me. But for a young adult who is driving and they are listening to the loud music, they see the police car, but it sounds like they don't care, but they don't have this connection between their limbic system, the fear amygdala, and their frontal cortex yet. So In terms of the cortex development, as you know, we have, ongoing and continuous development going until 24, 25, and in some extent until 30 years old. So we have sensory motor cortex to be developed earlier by age of 4, 5, 6, and then we have perceptive expressive language cortex to be developed, but higher cognitive function has not been developed yet, particularly the frontal cortex. So what are the stage of the brain remodeling that is happening? So there are different ways or different ways to remodel a structure of the brain. When we are born, we develop synapses with any specific stimuli that we are receiving, with lights, with different things. By age of 4, 5, we prune some of those synapses because we don't need that. I need all those synapses. And then we have a second age of the pruning, or pruning by age of 13 to 14, when we get rid of some of those pathways we don't need anymore. During adolescence and young adulthood, we have significant and huge increase in myelinization, which is the way that we make the processing more fast. So if you ask a question from adolescents and they don't respond, it's not like, they don't care. So they need more time to process and then respond to us. And as I said, another stage of brain development in this age is there's a significant drop in dopamine level, which leads to novelty seeking. So of course, all this development is under environmental factors or epigenetic factors and stress and hormones. And fortunately, we have neuroplasticity, which means that if anything wrong happened during this developmental stage, like trauma, big, adverse events during the childhood, we have this opportunity to change the structure of the brain with pruning and with myelinization. But if the adverse childhood effects or experiences happened, like being sexually abused, physically abused, growing up in a chaotic house, so those kids, have significant outcome clinically, including their, level of tolerance, level of motivation, or their empathy with others, or forward thinking, which is related to their frontal cortex development. So the first importance of the transitional age youth was about their neurodevelopment, biopsychosocial development. The second thing is that, as I said, and Dr. Motlagh stated and reported about the prevalence of the mental illnesses. So there is, 1 out of 5 adolescents, they have mental illness, and only half of them receiving services. And then when it comes to transitional age, which is, after 18 to 25, the number drops significantly. And we know that age of onset for many of them, or major mental illnesses, are between, 14 to 25. Anxiety disorder, first episode psychosis, and bipolar disorders. And we also have high rate of onset for substance use disorder during this age. 90% of transitional age youth had tried or used alcohol, and they have high rate of the binge drinking during this age. 60% of them have, tried illicit drugs, and close to 40% of them, they tried illicit drugs other than marijuana. And prevalence or the frequency of the substance use disorders are 21%. And the third reason for significance of this age group is about the foster care and what's happening in United States. So just give you a background about what the foster care is and what is the role of foster care here is that, as I said, there is a significant number of kids that they need to remove from their home, from their biological parents, to a foster home for multiple reasons. And this can be or should be determined by Department of Children and Families. It could be because of these kids being neglected, or parents are using drugs or so, or these kids being sexually, physically, emotionally abused. So there is a mandatory report here. When you see a kid, it could be in clinical setting or non-clinical setting, being abused, you report to Department of Children and Families. And then they do investigation and they decide if this home environment are suitable for this kid or no. So that's not that easy to remove the kid, because I mean, sometimes they provide mental health services or other services for family to prevent removing kids from their home. But even in interim, so those kids go to the foster care. But most of the time, I mean, if they go to the foster care, I mean, and the situation is more intense and the home is not appropriate for child to be raised there, then they stay in foster care until they get to the adulthood. So, but the challenge here is that the kid gets removed from biological parents, and biological parents, they lose the custody of the kid for whatever reason. And now the child is in a foster home. So many of these kids, they have, I mean, history of trauma, they've been neglected, they've been abused. So when they go to the foster care, there are multiple challenges that they face with. And the foster homes might not be suitable. They also might get, I mean, the victim of abuse while they are in foster care. That's a separate discussion. So, but the challenge here is that when they get to age of 18, they consider to be adult. Now they age out from the foster care and they from the custody of, I mean, government or Department of Children and Families. And now they consider to be adult and they need to take care of themselves. But these kids, as you can imagine, given their background, so they are not ready to be an adult. I mean, for normally grown kids, they might not really be skilled to practice as an adult in society. And kids aging out from foster care, they have additional challenges. So just giving you some, again, numbers and data about this, only half of kids that they age out from the foster care and they graduate from high school. And 1 of 5 of them, they get homeless 1 year after getting out from the foster care. And 1 out of 4 of them, in 2 years after aging out from the foster care, they get involved in criminal justice system. They go to jail. 70% of them, they get pregnant. So less than, 50% of them, they stay unemployed. And only 3% of them, they might get a bachelor degree in the longitudinal data. So in 2008, so legislation approved a law based on that. So they could increase the age of aging out from foster care. Now in the United States, in some of the states, so kids can stay in foster care until age of 21, and this is their choice. And also they provide more federational support to support these kids for their education and for their medical health insurances. So this, concepts that we discussed about development, mental illness, and the challenge of aging out from foster care make this age group vulnerable and important with specific needs. So now we deal with a population that they never manage their healthcare independently. They never made appointment with doctors. They don't have the skill, and they never been in pharmacy to get their prescription. And they don't know how to cancel, reschedule, or being on time for their appointment. So now we need to shape our practice to be more developmentally oriented based on their needs. And on the other hand, these kids are facing with significant stigma. Not only mental illness itself, having different identities, like gender identity, or being some of them to consider to be nerd or emos. Different kind of a stigma that this age population are facing with. So, and based on the data, many young adults that they had suicidal attempts, 50% of them, they never had any mental health service. So what are the aspects of the care that we need to consider working with transitional age youth? So there are some aspects of the practice that, so I just outline here, and then I talk about the services that we had at Yale University for young adult services. So when working with, young adults. So we want to have positive engagement in general speaking. I mean, regardless of where we are speaking, as a primary care provider, as an adult psychiatrist, we want to have our attention fully to them, and we need to build a rapport with them. We need to provide a safe space for them to express themselves and having significant amount of the empathy with them. And we want them to have the control of the treatment. So we wouldn't say this is what you need to do. So we give them options. And so we also, be clear about the boundaries and limits that we have. So other consideration is about, encountering with this age group is that, so their eating habits is different, their sleep hygiene is different, and their psychomotor activities are, varies. So we need to consider this into our clinical encounters. So what the program that I worked with was part of the program that's been funded by State of the Connecticut. So I put the map here. There are 5 regions that the Department of Mental Health in Connecticut considered to provide services. So YAS program, or Young Adult Service Program, funded by a state to provide more comprehensive and integrated service to this population of the transitional age youth, that they are usually underserved or unserved or inappropriately served in adult services, and they have emotional or behavioral issues. So this project or this program has been funded in 90s and has been continued for past 25 or 6 years now. And the goal for this program is to assist young adults to be independent and also reducing their hospitalization, and by providing service in the community and reducing involvement in criminal justice, and also reducing homelessness. This was a shared program that I worked with between Yale University and the state, which is quite unique. It's most of the time it's not working between academia and also state, but it was a very suitable collaboration. So Yale University provided some, academic human resources with the funding from the state, following regulation from the state and also Yale University. And this service included outpatient mental health service, specifically for transitional age youth, with no cost, and it was peer-driven. So we had significant peer support for this group. So in the clinic, we had a clinic supervisor who was a doctorate in psychology, a child psychiatrist, specialized or working with TAI for past 10 years, and residents who were rotating in that clinic, myself as a fellow, and psychologists and fellow psychologists that they were rotating in this clinic, and clinical therapists that they were either psychologists or licensed clinical social workers. And we had drug substance counselor and peer and family advocates, and we had vocational counselor and educational support counselor. So we had a big team for a small number of patients. It was a lot. Usually you might see multiple patients in the clinic, but when working with this population, we dealt with significant high level of clinical demands for one patient with very complex history and multiple comorbidities, which required more time. So what services that we had there? So we had individual therapy and group therapy counseling for them. We were able to provide intense case management for them and crisis intervention. So we had medication evaluation and management done by psychiatrists and fellow and residents. And we were able to refer them to the linked service for their medical needs or any other comorbidities that they had. We had, classes and groups for daily living skills that they need to have. So housing assistance, it was a kind of important part of our practice. For some of these kids that they were getting referred to us, so they were aging out from foster care and they had no housing. So we had some transitional and residential housing funded by a state to be available for these kids. It was not an easy thing to do. We had a wait list, we had to apply. I mean, it was quite, long wait list, but we had 3 residential housing in which we had, in which each of them we might have 5 to 10 clients to reside. And they were either 12 hours supervision or 24 hours supervision. And they had groups in the house, and we had our clinicians going to their house to see them. I had the chance to visit some of my clients in their house as well. They had transportation assistant, as I said, educational assistants and vocational counselor. And we also had, peer support for them. And we were supporting them with their application for Social Security, disability application, all these paperwork that they never trained or been practicing for it. So what I learned from my work working with this population and would be helpful to apply in any clinical setting for working with transitional age youth would be, is about the first step about how to communicate with these kids. So I'm not going to ask you what's wrong. So asking you what's going on, or what do you need? What are their strengths? Or these are things that's going to happen, not that, this is what you have to do. And also giving them option versus orders, and asking open questions and waiting for them to give us option. And we need to have social consideration here, as we talked about, their psychosocial development. So what is the dynamic between their family members, if any, or with their peers, if they have any friends? So knowing about their identity, is there any gay, lesbian, or their sexual identity and gender identity? And as Dr. Alokman stated about the implication of the social media and this new era of being connected with the whole world, it's not about them coming to my office. They know much more about, these things than I might know. So, and also looking for any adverse childhood events. Many kids that I worked with, they had significant trauma in their childhood, not only with their biological parents, also during their transition from one foster home to another foster home. And any risk factor for them to be marginalized in terms of their, culture, background that they have. So the setting of practice that I had with them, we had an office that we could see them, but we had significant amount of the flexibility. Usually when we practice, so if someone is late 10 to 15 minutes, we don't see the patient. But working with the transitional age youth, I'm flexible. What time works for you the best? I try to teach them boundaries, limits, but if they come, some of those, they will just walk in, whenever they want. So I don't say, I'm not going to see you, I will see you. For some of those patients, I need to be flexible about the setting of my office. So a traumatized case who couldn't sit at all, I had to walk with him in the hallway to talk to him to see what's going on. And as I said, and Dr. Motlagh stated about the practice to be more developmentally oriented. So we had a good, significant amount of the coordination of the care. And as I said, the kids' involvement or youth involvement is very important. And then we want to explore, what is specific about this youth, and what is about their individuality, and what are their strengths. We've tried to be more strength focused to develop the treatment plans for them. So many of these youth coming to transitional age clinic, they've been diagnosed with more than diagnosis. I had kids coming with ADHD, PTSD, bipolar disorder, schizoaffective disorder, and autism. So you want to consider those things in your evaluation, but slowly you realize that, the story was quite complicated, and every psychiatrist or child psychiatrist adds something. And now this kid's going to the adult service, and no one would like to remove this diagnosis because we don't know the whole story, or no one would kind of consider eliminating some of those medications that they are on. So because they have multiple diagnoses, So they have on multiple medications, lithium, Depakote, Lamictal, clozapine, and we don't know what we are really treating. So that's quite complex, but it takes time to make rapport with them, get to know them better, and then eliminating some of those diagnoses and having the core diagnosis. Because, I mean, we all know that diagnosing for this age is complicated. If they had any childhood onset disorder, it makes it more difficult and challenging. And they also had, fortunately, they had availability of a specialty clinic for first episode psychosis or a mood disorder clinic. So we had chance to refer them, but having them connected to the young adult service was sufficient enough. So with the resource that we had available. And one of the important aspects about working with transitional age youth is to be trauma informed. And our clinicians, they had training working with kids that they've been traumatized. So because they need to build a trust. They are coming from the background that they had no sustained relationship with their parents, or they've been transitioning from one foster care to another foster care, and they have this feeling of unwanted, and they never had this ongoing relationship that they can trust, even they act out. So being trauma-oriented therapist and clinician is important working with this population. And then again, in line with previous comments, being authentic and don't promise things that you cannot do with them because they want to trust you. And if they need any information about other aspects of their life, this is important. If they don't know how to fill the prescription, so what is the point of me sending the prescription? I need to teach them about those things. Yeah, mentorship and having the community-based services, as Dr. Motlagh stated, the model in Australia is something that is working for transitional age youth. And another aspects of the work with this population is that some of them, they go directly to work. I mean, but they don't know how to search for work. They don't know how to be prepared for the interview, how to apply for a work, how to prepare their CV, or so in our practice, we had vocational counselor that they were able to practice the interview, and we were supporting them going to the interview for their job. Or if they are going to the college, they need to be prepared. They never, I mean, usually transitional age youth, if they have no emotionally disturbed situation or they had a safe family, they have family helping them with college application, with their furniture when they go to another house. But for this population, it's different. So they need to have additional support for these skills as well. And then if graduate from college and they want to go to their first job, the same thing. So they are in a better place, but they still need more assistance. And many of these transitional age youth, they never lived independently. I mean, most of them. So when they age out, they need to learn about basic needs. As I said, they didn't have nurturing family. They don't know how to clean their apartment, how to do laundry, or budgeting. So if they get some money from state to support themselves, so they might just spend all of them in the first week. I mean, they need to teach them how to finance, how to make your budget, and how to pay their bills. I mean, for water, for power, or for phone. And also teaching them how to navigate the system. I mean, what we had in YAS program at Yale was that, so we were continuing supporting them. And then when they were getting to be graduated from the service, we had this discussion 1 year ahead. I mean, we were have them to be graduated at age of 25, but we had this discussion for a long time. And then we had a kind of celebration or a ceremony for them to be graduated from young adult service and to be ready going to the community to be independent, and then teaching them and coaching them about the resources that they can get from the community. That's all I have for today. I hope we learned about the importance of the transitional age youth and some of the aspects of their development and some strategies that we can apply delivering the service for them. Thank you.
Thank you very much, Mario. It was very helpful, and it was very interesting. Um, the topics you covered, and I really appreciate.
Of course.
So now we have a few minutes to perhaps to any comments or any questions. I'm sorry, did you say something, Maria?
That's
Oh.
me.
Okay. So if there is no question, I could I think we could finish and say goodbye. Okay, thank you everyone, and thank you Maria, thank you Dr. Motamed, and everyone who's participated in this webinar, and best of luck.
Thank you.
Thank you so much.